Hi everyone, Tyler Houston, and I'm doing this presentation on multiple oppositions intervention. This approach was developed by Dr. Lynn Williams in 2000, and it's a type of contrast therapy that focuses on producing contrasting word pairs instead of individual sounds. Williams defined this approach as a variation of the minimal opposition contrast approach that uses pairs of words contrasting a child's aorist sound and 3 or 4 strategically selected sounds that reflect both maximal classification and maximal distinction. An overview of this approach, Williams described it as a paradigm with 4 phases. Phase 1 was familiarization, and this is where the child discovers sounds and rules that were being trained and familiarize themselves with the targeted words. Phase 2 is production of the contrasts and interactive play. This is when the child imitates sound contrasts and targeting sounds with stressed intonation and physical prompts. Phase 3 is contrasts within communicative contexts. This involved naturalistic play activities and gave opportunities for the child to produce sounds. Phase 4 was conversation recasts. This is when the clinician would give feedback to normal conversation production. So when to use this approach? Williams specified in her studies that the child must produce at least 6 sound errors across 3 different manner classes, have a severity level of moderate to profound, be between 3 and 6 years old, and exhibit typical hearing and intelligence and have normal function and structured speech mechanisms. This is an example that I created from using the multiple oppositions therapy guide. So we have a child that collapses the k, b, h, gr to the voice stop g in the word initial position. So cards will be made before the session that focuses on the 4 targeted sounds and contrasted sounds using rhyming words. So goo, grew, coo, boo, and who. Clinician will hold the goo card beside their face and say the targeted sound with tactile, visual, and or auditory cues, followed by the word. Then the child will imitate. Clinician will contrast goo with the first of the contrasted cards, grew, by using tactile, visual, and or auditory cues for the initial sound, followed by the word, and the child will imitate. Once again, the clinician will hold the goo card beside their face and go through the same sequence as before, this time contrasting the goo card with the coo card. And repeat the same procedure throughout all cards, making sure to contrast with the first card, goo. And here is a demonstration of this approach that was created by 2 grad students.
Ooh, are you excited to be in therapy today? Okay, we're going to do some fun stuff. Do. Do. Like the raindrop sound. Can you say it? Do. Good job. Foo. Very good. Do. Do. Goo. Goo. Very good. You can feel that in your throat, can't you?
Some strengths and weaknesses of this approach. Studies done by Williams and Allen both indicated that the greater intensity yielded greater treatment outcomes. And an article by Williams she said that this approach is systematic and aligns phonological assessment, target selection, and intervention, which is more effective than other approaches that are not systematic. And the same article, she stated that it helps students understand phonological rules by generalization. Some weaknesses is that it's harder to learn compared to singleton contrasts, but because there has only been one primary researcher, there is not much evidence against this approach. My recommendations based on reviewing this approach, I think it depends on the child. It gives the clinician flexibility to individualize each case, and it reduces the time a child has to spend on a treatment. And since SSD correlates with reading difficulties, the sooner the disorder is treated, the better. But it also has potential to frustrate the child. So multiple oppositions approach is recommended if the child fits this criteria.